Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. We're grateful to Blood Cancer Today for us to be able to share with you some of the exciting updates on the diagnosis and therapy of patients with myelofibrosis. So let's switch to pacritinib and momelotinib, which I think in many ways, address kind of perhaps a larger unmet need in terms of cytopenias. After their approval, pacritinib approved first back in 2022. So, Toyosi, pacritinib, where do you use pacritinib? Have you used it in the front line? Do you use it in the second line? Is that a platelets of 50? Is that platelets of 100? Is that higher? How do you use pacritinib?
I use pacritinib generally in the setting of thrombocytopenia. Of course, I'm talking about post-pacritinib approval now versus all of the, times when it was in development and, clinical trials that we participated in. But since it was FDA approved for use in patients who are thrombocytopenic, I really favor it in that setting. Because when you have someone who has a platelet count of like 20, 25,000 coming in and with a big spleen and symptoms and needing JAK inhibition, it's just really tough to reach for ruxolitinib or fedratinib, in that setting. So that's sort of generally when I've used it. And of course, I've used it in the frontline setting in those individuals. It's clearly less myelosuppressive.
And Sanam, clearly when we're getting to patients with cytopenias, there's a range of potential reasons why they're cytopenic. It can be drug effect, clearly it can be progressive disease, or it could be something else. From your end, in terms of the what you're looking for, both in terms of do we repeat a bone marrow, do you repeat the NGS, do you look for other molecular markers, do you look to see whether there's been evolution toward an MDS or an AML? What's kind of the spectrum? And you guys are seeing probably very complex cases coming through MD Anderson.
Yeah, that's a great question. So I think knowing the natural history of the disease, and just thinking about a fibrotic bone marrow, as these patients progress through their disease, their hematopoietic reserve is depleted, and so they can't make platelets, they can't make red blood cells. So that's partly the reason. But then, what you very nicely pointed out is, again, progression of disease through genetics and clonal evolution. One thing that I want to point out, and this is mostly by convention, is that we never give a diagnosis, like a secondary diagnosis of MDS to a patient that has MPN, right? It's always considered progression of their disease. So we will say, there's features of dysplasia in the bone marrow, and this may indicate that the disease is progressing, but we'll never reclassify the patient as having an MDS-MPN now, right? But then obviously having increased blasts. So I think any indication, any dramatic change in the patient's blood counts should really, trigger a bone marrow evaluation again, because there's often a reason that can explain the patient's cytopenias, usually progression of disease.
Sure, although not always. I mean, it's always
Absolutely.
good to really have the wide differential, because, we've all had cases where, again, the bone marrow shows metastatic carcinoma.
Oh, absolutely, yes.
You talked
You'll
about
see
Definitely,
that.
yeah.
I've seen patients who clearly were iron deficient, and that really was masked. But it was linked to, I found uterine cancers, I found colon cancer.
Yeah, absolutely.
So always be mindful, does it make sense? But just be certain, because again, these other things, you don't know they're there until you look.
You have to look. That's a great point.
You just have to look. Naveen, pacritinib toxicity issues to manage, anything on your radar?
This is an important question, for all of us on the clinical trials. There was some discussion through the years of drug development with pacritinib. There was some scrutiny with, what we call MACE events or major cardiac events and bleeding. Although in the clinical practice, I have to say for me, haven't seen very much of those. So cardiovascular events or bleeding, we know about. I think those haven't been an issue, but I will say two factors have been. GI again, so it seems to me post-Rux, actually all three of these, right, fedratinib, momelotinib, and pacritinib, GI side effects. Again, when you come into the real world with these JAK inhibitors, you have patients with Crohn's disease, prior colon cancer. Interestingly, pacritinib has a signal of diarrhea, I would say, Ruben, in the first 4 to 6 weeks. It calls to mind bosutinib, which is the only other drug I can think of in CML that does that. So the first few months, we're really on red alert. And again, the pacritinib, actually, when you prescribe it, it actually literally comes with Imodium when you prescribe it. So diarrhea and GI. And then the second issue is that you can have patients who are being treated at a very severely low platelets, right? By definition, in the front line, you're giving it less than 50. So I really do watch out for thrombocytopenia, platelet transfusions, bleeding, those secondary events, even if they're not happening first.
Wonderful. Tertiary, let's migrate to momelotinib. So the most recently approved, September of 2023, broad label for anemia. Are you using it in the front line, using it in the second line? You know, in whom do you pick momelotinib versus pacritinib?
Yeah. So I am using it in both the front line and the second line. So, and it's really anemia that drives my reaching for momelotinib. So if somebody comes in, and I, like you, Ruben, I'm always telling anyone who will listen, you have an anemic patient with myelofibrosis, you look at it through a wide lens. You don't naturally assume that the anemia is driven exclusively by the myelofibrosis. So if they haven't had a recent bone marrow, yes, I will do a marrow, especially if the dip in the counts is recent, right? And I do a comprehensive anemia workup. I found all kinds of things. My favorite one is severe hypothyroidism.
Sure.
Oh, wow.
You know, so it's like, oh, myelofibrosis is progressing, patient feels awful, and also anemic, and yeah, that was I felt so good given Synthroid, never felt better.
Yeah. It's like there's nothing better than like a B12 deficiency. It's like, oh my gosh, and give some B12,
Yes.
you know, and people respond. I mean, it's just
Yeah.
so rewarding.
Right, exactly.
Yeah.
So, but you know, of course, in many patients, it will be driven by their myelofibrosis. And if they're on anything myelosuppressive, I will take that off, discontinue if they were on Hydrea or whatever. And I will reach for momelotinib, particularly if the hemoglobin is like, 8.5, 9 range, a range where I know if I reached for ruxolitinib as the first line, I might render that patient to start needing transfusions. I'm trying to avoid, adding a new burden on the patient. So that's when I generally use momelotinib.
Wonderful.